All right, well, we'll go ahead and get started. Welcome, everyone. This is the Psychedelic Support speaker series, and I'm Dr. Allison Fiducia, the founder of Psychedelic Support and the host of this series. We're really excited to have you all here, and I want to introduce our special guest today, Andrew Penn. He is a board-certified nurse practitioner and psychiatric nurse practitioner. He's trained at the University of California and has extensive training as a psychedelic-assisted therapist at the California Institute for Integral Studies. This is CIIS, and they have a certificate program for practitioners to become licensed to deliver psychedelic therapies. He's also the co-founder of Open Nurses, which I dropped a link in the chat. I highly encourage you to check this out. It's a professional organization for nurses interested in the topic of psychedelic medicines. Andrew is also a therapist on the MDMA-assisted psychotherapy trials with MAPS and the USONA-sponsored trials for psilocybin-facilitated therapy for major depression. And he's one of the rare people that actually has experience working with MDMA and psilocybin this far in the clinical trial setting. So we're really excited to hear his experience as a nurse and the parallels he's brought and perspectives he's brought from this field. And it's really a multidisciplinary field of psychedelic medicine. So it's great to have Andrew here to tell us more about this work. So thanks so much for being here.
Yeah, thanks, Allie. Thanks to you and to the rest of Psychedelic Support for having me. It's nice to see some familiar faces in the room. So I'm going to assume that for purposes of this talk, that most people are probably familiar with the psychedelic therapy model. So I don't need to get into, the differences between placebo and study groups. So I'm going to forego that part. And really what I'm going to focus on is the care that we deliver to patients, we call them subjects in the studies while we're treating them. So that's really what I'm going to be focusing on today. By way of disclosures, I do get some salary support for my work on these two studies that Allie mentioned. I worked on the very tail end of the first half of phase 3 MDMA PTSD study that was sponsored by MAPS, and I'm currently a co-investigator on the UCSF site of the phase 2 psilocybin study that USONA is sponsoring. And so obviously these are all off-label uses of the drug because there isn't a label yet because they're not FDA approved. And this is really intended to be kind of an idea generating presentation rather than more of a data-driven one. So I won't pummel you with graphs, which you'll probably be happy to hear. So I'm going to talk about the different ways of approaching treatment, really. And because I'm a nurse, that's my training. That's the sort of way I come at this. And this talk, I've given it before. It's got about 40 minutes of material or so I'm happy to do questions afterwards. I found one thing teaching over Zoom is that I'm really terrible at talking and reading a chat box at the same time. So if you want to chat, you're welcome to, but I won't see it until afterwards. So there you go. Again, I'm sort of preaching to the choir here, but you all know that this is a growing field of study. Every year, it seems like there's more and more papers published. There was a time when I had read all of them. I don't think I'm at that point anymore because I'm trying to keep up. And one of the things that I love about psychedelic therapy is that it brings together two things that I am really quite passionate about. So I was trained as a psychiatric nurse practitioner. Psych NPs have competencies in psychotherapy, but primarily our role in the healthcare system has been to do psychopharmacology. And that's fine. I was really into psychopharmacology for a while. I thought it was super cool to get to prescribe medicine and do neat things with it. And then after about 10 years or so of that, I got a little disenchanted with it, I suppose you would say. And I was reminded that really what I'm passionate about is psychotherapy. And so what was cool to realize about psychedelic assisted psychotherapy is it takes those two things that I'm most passionate about and uses them to potentiate one another. So psychotherapy is fantastic, but it can be really slow, as you all know. Psychopharmacology can be really helpful in alleviating suffering and reducing symptoms, but it doesn't really heal. And so by bringing these two things together, there's potential of really maximizing both modalities. But the problem is, because the way we've been trained is these are therapists or psychopharmacologists, and just setting aside researchers out of this for a moment, there's this gap that Matt Johnson has pointed out that that we really need to bridge in order for this to work, because this is more than a drug, and it's certainly more than therapy. So how do we do that? And so that's what this has really been thinking about. So, up till now, a lot of what we've done in psychedelic therapy has been a little bit of this black box model, which has often dominated in psychopharmacology. So we say there's somebody who's got depression, we give them this treatment, we put these mushrooms or MDMA, whatever it is, and out on the other side comes this changed person. And that's a good thing, right? And I agree, it is a good thing, but I'm really interested in what happens inside that box, and how does the experience of the patient and how does the behavior of the therapist change that outcome? How does it influence that outcome? Because I don't think it's just the drug. I think the therapy piece is so critical here that to ignore that is really at our own peril. Now, one way that we've traditionally looked at pathology in, and this tends to be the worldview of medicine, is that there's a disease that happens to live inside of a person. And so oftentimes when we talk from this model, the person gets kind of eclipsed. Their identity, their values can get lost. And we talk about the MI in curtain 6, or the whatever condition it is. The person becomes their diagnosis, and it can really, the humanity can get lost in that. Now, this singular focus has often given really great results. I would not want to be having my cancer treated 50 years ago or something like that, or 100 years ago, when we didn't have these focused treatments that we have now. So there's been great yield to this. But the problem with applying this to psychiatry has been that we have taken this sort of old idea, right? I think it comes from Buddhism, that pain and suffering are not necessarily the same thing. That pain in psychiatry might be adverse childhood experiences, or even something like depression. And then suffering is our relationship to that inherent pain. And that suffering can take the form of avoidance. It can take the form of being overly attached to that pain. But regardless, our relationship to the pain changes our experience of suffering. And we took this idea from microbiology of a lytic treatment, that you could just sort of poke a hole in an organism, like a germ, and the guts leak out and the problem goes away. And this is reflected in the nomenclature of some of our medications. We talk about anxiolytics for treating anxiety, as if we could just poke a hole in the anxiety and it would just go away like an infection. And the reality is that I think a lot of psychiatry is inherently palliative in nature. We don't really cure things, and that's okay. This is not a knock on palliative care. Palliative care is critical because it changes the relationship to suffering, but we're not curing anything. But maybe we could. And that seems to be the promise of psychedelic therapies, at least at this point. We'll see how that plays out over time. So where does nursing come into this? Well, nursing takes a different view of disease. So we look at disease, of course, but we also see that a disease happens to reside inside of a person, but it is not the entirety of that person. It's just one aspect of them. And it's one aspect that exists on this wide field of sort of possible important existence, right? So other things that exist on this field is that person's family and important relationships, their ideas, their relationships, their love, their work. And we're on this field too as clinicians, but you see, we're not centralized. We are consultants. And one way we can look at this is a curative model. And so this idea of psychedelic-assisted therapy, this basic model, right? So you've got preparatory therapy that bookends the drug session itself. I'm not going to get into the details of this because I'm assuming that most people in the audience already know how this works. And then we have integration afterwards. So obviously the drug is not taken every day. like traditional psychopharmacology, this is something that is done maybe once, maybe 2 or 3 times, but always in a controlled setting, always there's always non-drug therapy that happens before and after, where we prepare that patient for the experience and we help them make sense of it afterwards. But the more I thought about psychedelic therapy and nursing, the more I thought about how it resonates with the ethos of midwifery. That in midwifery, we take the idea that the body knows how to give birth. We've been doing this for thousands of years. Sometimes it needs a little help. Often what it needs is support to allow that natural occurrence to happen. And that's what we're doing in psychedelic therapy. This is not a new idea in nursing. So one of the wonderful things that I found in my research for some papers that I've written in this last year was a nurse named Kay Parley. And so many of you probably know that that there was this, what is sometimes called the early period of psychedelic therapy. Obviously, psychedelics have been part of human culture for 6,000 years, at least, maybe further back. But there's the modern era of psychedelic therapy, or psychedelics, is often thought to begin in 1938, when Albert Hofmann synthesized LSD. And it continued until 1970, when the Controlled Substance Act really kind of shut down a lot of these research and put these drugs onto Schedule 1. But there was this period of time in the 1960s, 1950s, where people were doing serious research about this, and they were publishing it, and they're having conferences about it. And it's really kind of a hidden history. And I was interested, well, what were nurses doing during that time? And I found this amazing article in the 1964 article in the American Journal of Nursing by Kay Parley, who was a Canadian nurse working with Humphrey Osmond, who was a well-known researcher and clinician up in Canada, who was treating patients with what we would now call alcohol use disorder. And Kay was a nurse working with him. She has a fascinating history of her own. There's this wonderful book that she wrote called Inside the Mental, which I don't have time to get into, but I would encourage you check her out. So she was taught, she had these lines like, the nurse-patient relationship during LSD treatment is, I suspect, like that between partners on a mountain climbing team: warm, cooperative, intimate, and yet objective. And I just love this. And so she wrote this very sober article in the 1964 issue of the American Journal of Nursing. And so I'm happy to report that, along with several of my colleagues, Carolyn Dorson, Stephanie Hope, and Billy Rosa, we wrote a follow-up to this that was published this year, 57 years after the original article, talking about the current state of psychedelic-assisted therapy. That was the cover article on the American Journal of Nursing earlier this spring. And these are all available articles. You can also get them off my website, which I'll share with you at the end. So I started thinking about, how can we bring these nascent ideas of what it is to be a psychedelic-assisted therapy. So Janice Phelps, who many of you probably know, she directs the Center for Psychedelic Therapies and Research, CPTR, at the California Institute for Integral Studies, which, as Ali mentioned, I'm a graduate of from 2017. And so Janice has started to articulate, what are these qualities? So things such as increasing the amount of trust that the patient has in us through this empathic abiding presence, understanding how psychedelics work in the body and how they work in the mind, having some capacity for understanding spiritual experiences, being self-reflective and behaving ethically, and then finally being able to use complementary techniques where appropriate. So I took Janice's idea, and with her help, and with the help of my colleague Billy Rosa and Jean Watson. So Jean, if you're not in the world of nursing, you may not be familiar with her, which is a shame, because Jean has been a real force of nature in the nursing literature for about 40, 45 years now. She's been at this for a long time. And I remember reading her theoretical work when I was in nursing school, and honestly, most of it was completely baffling to me. It was kind of mystical. I was kind of a rational materialist at the time. And I thought, this is a bunch of, I don't know, I don't understand it. So it's funny how we circle back to things. So, here it is, nearly 20 years later. I'm trying to think, what's the nursing perspective on psychedelic therapy? And I reopened Jean Watson's work, the encouragement of some colleagues, and it's like, whoa, she was writing about this way before. So that book right there with the familiar Alex Gray painting on the front, that was in 2001 she published that. So well before this kind of current era of psychedelic therapies. So I wanted to take her ideas, which I'll talk about in a second, and marry them with some of these emerging ideas around psychedelic assisted therapy into something I'm calling psychedelic caritas nursing. So Jean talks about these caritas principles as really what informs nursing care. And what she's really pulled off there, which is impressive, is describing something that's quite ineffable. And I think if you've ever been a patient, or if you've ever known somebody who's a patient in a hospital, for example, they'll tell you things like, oh, I got great care, or I had terrible care. And when you ask them to say what they mean by that, a lot of time it's kind of a felt sense. And so what Jean has done is really kind of unpacked that and articulated in a very fine-grained way what is the process of care in any kind of human relationship that involves treating another person. And that really at the heart of it is that this healing takes place in the context of a relationship, and that suffering is reduced in the context of this relationship where the person feels supported, cared for, and there's an experience of empathy. So that's really at the heart of this idea here. And my hope is that what happens in psychedelic therapy, and this is increasingly, I'm thinking that psychedelic therapies are not going to eliminate the mental illness, be that depression or PTSD, but rather what they will do, I mean, they may look that way because on paper, people's symptom rating scales go down and such. But if you talk to people qualitatively, they'll tell you what really changes is their relationship with the experience, with that pain. That now, instead of that orbital of suffering being kind of adhered to the experience of pain, there's now more spaciousness there. And because there's more spaciousness, the person has a different relationship to their experience of pain. So for example, a patient of mine who I wrote about a few years back, who was a subject in this phase 2 study of MDMA for PTSD, she still has those traumatic experiences. Of course, this is not a memory obliterate, but her relationship to those traumatic memories is vastly different. And it's what allows her to have significantly less suffering. So I'm interested in thinking about how we can use this process to enhance this change in relationship. So we wrote about this earlier this year in the Journal of Humanistic Psychology. Happy to send this to you if you want, or it's on my website. And really, this talk is the overview of that paper. Now, there's been a lot of talk in the psychotherapy area of what modalities will work well or can be adapted to psychedelic therapies, such things as internal family systems or acceptance and commitment therapy. And I see this approach as being complementary to all of them. So this is not instead of one of these therapy systems. This is a way of being as we bring that therapy to the patient in the psychedelic framework. So this is I think can be used across different theoretical approaches. So what does this look like? Kind of preambled enough. So really there's sort of two, you can think of this as two large buckets. So there's how do we tend to the patient, and then how do we tend to ourself and the world around us? And each of these boxes is one of Jean Watson's Caritas principles. So we start, and I'll elaborate on these in a moment, but we start with creating this trusting relationship that allows us to not only learn from the patient, but to teach them, because we're always engaged in this sort of bidirectional teaching, learning experience when we're nurses, or any kind of clinician, really. But I always tell my students that patient education is not just some perfunctory thing that we do on discharge. It really is a central intervention as we help people understand their condition and how they can best serve themselves and treat it. That we have to do this with a sense of authentic presence. We really can't just dial this in. because this is very intimate work, as you well know, and that we respond to whatever emerges from the patient with a sense of loving kindness and equanimity, that really anything that emerges is welcome. Whether that's positive or negative, it's okay. Whatever you bring here is welcome. And that finally, we get to be kind of playful. One of the things that's fun about psychedelic therapy is that there is a kind of playfulness that happens. My last therapy session I did, the person about 45 minutes in sat up and took off their eye mask and just started giggling. And then I started giggling and my co-therapist started giggling. And it was one of those things that I don't even know what we're giggling about, but it was kind of infectious. And she just looked up at the wall and she said, "That picture's not supposed to be moving, is it?" And I said, "I don't know." But, we get to have some fun here, right? I see in the audience is one of my old colleagues who's a music therapist, a very skilled music therapist. And we worked together over 20 years ago now at the San Francisco General long-term psychiatric facility. And the most fun I ever had with my friend Michael was doing drum circles and sing-alongs with patients. We got to play in a way that we never did in other kinds of treatment. So talking about tending to a larger sense of the world, this is often a very spiritual experience for people. So how do we help them with that? And how do we develop our own self-awareness around our spiritual lives and to be open to that? How do we communicate that we're open to that? We want to create a healing environment in the physical space. This is kind of, again, nursing 101, right? First thing I learned how to do in nursing school was wash my hands and make beds. Because you know what? When you're sick, you don't want your sheets rumpled. You want to be comfortable, right? So that's a very basic nursing skill that is important. And then finally, this idea of we are taking care of our patients' physical bodies. And sometimes those are bodies that poop and pee and snot and do all sorts of things. So how do we support the patient's physical body in that? And I think this is somewhere where nurses are really quite good at that. So a metaphor that I often use in this is that this is a remodeling project, that we are remodeling your internal sense of self, who you are in the world. And it's a collaborative process. I'm not coming in and saying, this is how you should be. I'm going to work with you and try and help you develop some intentions about how you want to be. And in order to do that safely, we create this container that is physical. So we have a safe, comfortable space to do this in where we're not going to be interrupted, where it's private. But also we have this relationship between in this case, two therapists, which has been the extant model so far in most studies, where those therapists really understand that patient interpersonally, psychologically, so we kind of know what's going to come up or what might come up. And that helps to engender a sense of trust. Now, I did this remodeling in a very literal way a few years ago when we took our vintage 1985 apartment with its lovely kind of beige kitchen here that blocked this beautiful view of the coast, and we transformed it into this. Now, in order to do this, it was really messy. So we lived here while we were doing this. This was my kitchen in the middle of all of it. And in order to pull this off, we needed a guide. This was Pascal, our contractor. Couldn't have done this without him. It would have been a lot worse had I tried. And I think the same is true for psychedelic therapy. You need a guide. You need somebody to help you through it because, we think we're going to go from A to B, but really it's often not that linear. Things can get kind of messy before they get better. Like any therapist will really tell you, right? That if therapy is really going to come with informed consent, we got to tell people sometimes you're going to get worse before you get better. And it's the relational aspect of this, which is why I really think there's a critical human component here. And I know there's been a lot of interest in trying to scale this up and increase access by maybe moving some of this onto an app or even using AI. And I have to say, it makes me a little uneasy to think about people sitting and doing this on their own, because I think that these treatments are deeply interpersonal, and that even if we can assure the physical safety, that really to be witnessed by another, not by your phone. My phone witnesses me all the time. I don't think my phone gives a damn about me. I think I care more about my phone than my phone cares about me. But that's not being witnessed. That's just maybe being observed. So if I'm going to have somebody come in and tear my house apart, I got to trust them first. And I have to let them in. I can't just show up in somebody's house and say, we're gonna fix this place up. That sounds like some kind of makeover TV show, right? But really, somebody has to be invited in. And after they're invited in, they begin to learn how you live in your house. They begin to make suggestions based on what they observe. But when they've done their work, they leave. They don't stay forever. And that's similar to the psychedelic therapy process, which is often time limited. And as we develop this sense of trust, this idea of an inner healing ability can then begin to emerge. So Florence Nightingale talked about this in the 1860s. She said that it's nature that heals the wound. We just do things to support it. And Annie Mithoefer said something very similarly, 140 years later, talking about how it's this trust that allows this inner healing intelligence that Stan Grof wrote about to emerge. That we can make the conditions favorable, but we can't make this happen. It's the internal healing ability of the patient, which is what gets them better. So in order to flesh out the paper that I wrote with Dr. Phelps and Dr. Watson and Dr. Rosa, we borrowed some qualitative material from the work that Alex Belser and Cody Swift and their colleagues did at NYU, looking at the cancer anxiety psilocybin study. And so we wanted to flesh out these ideas that could be a little abstract. But they talked about this feeling of trust, the feeling protected, that feeling of trust allowed patients to feel safe and protected, and that this interpersonal process of understanding was really what helped to undergird that kind of trust. So that this relational aspect is critical to developing the sense of trust so that people can let go and have these experiences. So once we have that trust, we have to, of course, maintain it. And we do that through being empathic, through behaving in an impeccable way. And what this allows us to do is to then begin to see how the patient sees the world. And once we understand how the patient sees the world, then we can engage in this teaching learning experience. So we're learning how the patient sees the world. And this is why preparation is so important, because we're creating these intentions of what do we want ourselves to look like after we get through this. And that's a collaborative process. But it also means we have to poke around in the basement a little bit. If you've ever renovated an old house, you find surprises in the walls, right? And so this is part of what we're trying to get a sense of in preparation of what challenges might arise as we're entering this psychedelic session. So Martin Buber, the philosopher, talked about the difference between an I-it relationship, which is really that of an objective observing relationship. So it's me looking at another person in this somewhat objective way, right? The problem is this also kind of reduces that other person to an object. They're not a fully engaged human being. So he advocated that this should shift to what he called an I-thou relationship, where we really honor the person fully. And what this does is this allows for this intersubjective space to arise. And it's within that intersubjective space that we can really authentically attend to that inner world of the patient. And that, again, deepens this sense of trust that happens with this care. And of course, we have to do this very thoughtfully and carefully because these medicines are very intimate. They engender very strong emotional feelings. So our boundaries have to be excellent, but they also have to be humane. So if we're overly rigidly bounded, we can scare somebody away. We can make them feel ashamed for their feelings. But if we overstep our boundaries, then that creates confusion and possibly even harm about the relationship that the person has with the patient. So this has to be done with a lot of care, probably a lot of supervision, and a lot of thought. So what did this look like for the patients, this experience of intersubjectivity? Well, they picked up that really everything mattered in this state. I remember Bill Richards teaching us, like, when you're doing a session, put your phone away. This is not a time to be answering your emails. Even if the person is sitting there with their eyes closed on, with their eye shades on, sit with presence, because people are going to sense that. And also this also allows us to observe things which might otherwise be too subtle to be noticed. So this was a line from a patient who'd had breast cancer, and the therapist pointed out that every time she talked about the breast cancer, she would sort of unconsciously touch her chest. And he pointed this out to her, and she said, it's like I'm trying to rub out the cancer. So she could develop this deeper awareness through his observation of her behavior. Now, I get asked this question a lot, like, so what do you do during the therapy session, right? Like, are you doing CBT, or are you doing exposure therapy? Are they filling out thought records? And the answer is generally no. So what are we doing? We're sitting there. And it's like that old bumper sticker, don't just do something, sit there, right? So we're holding this empathic, abiding presence. I think of it as a sort of bodhisattva energy, that whatever comes up is welcome. And that can be positive, that can be negative. That same person that was giggling incessantly was crying their eyes out 5 minutes later. So these emotional states can be quite labile. And a lot of times our anxiety as clinicians makes us feel like, oh my gosh, I have to do something, right? I have to make them feel better, or I have to quiet them down so the lab next door doesn't get upset with us, or, and the reality is we just have to be able to sit with this stuff. And that also communicates to the patient, to the subject, that whatever they bring into the room is welcome. And this is also why, you can't go any further than you've gone yourself. You can't take a patient any further than you've gone yourself, which is why our own personal work and self-reflection is so critical. Now, we all avoid doing this stuff, right? So I got a COVID dog. I'm not sure this was a great idea, but I got a COVID dog. And this COVID dog, love him, but man, he's mouthy. And I learned very quickly that if you try and pull your hand out of a sharp mouthful of puppy teeth, you're going to get your hand ripped up. So even though it's totally natural to want to get your hand out of harm's way, you actually cause yourself more harm. And what you need to do is push your hand into the dog's mouth. And if you do that, it'll open its mouth and you can get your hand out. But it's not intuitive. And I think a lot of times we encourage inadvertently this kind of anxiety avoidance. So, whether or not that's, oh, we need to increase your medication, or, we need to get you into a higher level of care, or whatever it is, we sometimes collude in avoiding these experiences. And what we're seeing now, brief aside, in psychopharmacology, is that there's this concern that maybe long-term SSRI use, for example, actually blunts people's emotional experience. And that what psychedelics actually do is enhances them in a brief and intense way that allows the person to feel like they have a greater sense of mastery over those emotional experiences, in a way that general sort of blunting of those emotions with medications may not allow for. So again, going back to what do we do during the session? We kind of do what my dog is doing here. We chill out, right? We rest into it. And we go into this with this delightful sense of, I don't know what's going to happen, but I can't wait to find out. Right? We're pleasantly surprised because we don't have these tight expectations. And by us communicating that in our own behavior, we give our patients permission to not have overly rigid expectations. And there's a lot of expectation management that needs to happen in this work, because Lord knows a lot of the people seeking us out in these studies are really desperate and they want to feel better. And I get that. But again, this is a time when sometimes allowing something to unfurl naturally has a real benefit. And it's tempting to want to talk during these sessions. And Florence Nightingale, again, here, 1860s, talked about this tendency of patients' families and loved ones to come in and talk at them, right? And what are they doing? They're trying to make themselves feel better. They're hoping they're trying to make their loved one feel better. Really, they're trying to make themselves feel better. And oftentimes they make the patient feel worse. So she called it the chattering hopes for the sick, which I love. One of my teachers said she used this acronym of WAIT, which is in a therapy session. If you're talking, ask yourself, wait, why am I talking? Is there actually something useful here? Maybe not. Maybe silence is actually the better option. So what happens when we have that silence, when we have that spaciousness? I mean, that's the beautiful thing about a psilocybin session is that you got 7 hours with that person, right? So what's going to happen during that time? You got no place to go. You don't have to be anywhere. You don't have to do anything. Turning your phone off. You are offline. What might come up? Well, one of the things that sometimes comes up is grief. And, we talk about psychedelics being egolytic compounds. And I think one of the functions of the ego, however you define that, is that it holds back unpleasant feelings. And one of the things that many of us, almost all of us, it's a human experience, are carrying around is some degree of grief. And I think this year has certainly double underscored that experience. So when that defense comes down in the psychedelic session, this lake of sort of unmetabolized grief can come crashing forward. Now, that grief can be personal, it can be from our own lives, but I'm increasingly seeing it being ancestral as well. And I think this is really one of the phenomenon of some of the social justice movements of the last couple of years that really underscored is that we are all at the spear point of many generations of experiences. And for many people, their familial experiences, embedded in them is a lot of grief and a lot of hardship, and that it's not that long ago. And maybe it's still happening. It's like Faulkner said, the past isn't past. It isn't even past. The past isn't dead. It isn't even past. So what was it like for patients to experience this? And they said that this grief, that in the case of these folks that had gone through cancer, that their life had changed significantly so quickly, and that they really had not had the opportunity to metabolize that. And Kay Parley talked about this in her 2016 memoir. She was talking about how that you really are like mission control for these folks. You are their guideline back to where they've come from. We often will use this metaphor of a boomerang, that you may go way out into your thoughts and feelings in your life today, but I can assure you, you will come back safely right here. And so we are that lifeline back to them when they are deep in this work. Now, we know that many times people have spiritual experiences during this, however you want to define that. And so it's incumbent on therapists, nurses, whomever is delivering this care to be at least comfortable with that. They don't need to follow the same practice. They certainly don't need to have a religious practice, but I do think they have to have some capacity for appreciating not only suffering, but also the spiritual aspects of our larger existence. What happens when we're not here? What happened before we were born? As Tony Bossis likes to say, those are questions that are above my pay grade, which I totally appreciate because I don't have the answers to them either, but I have to be willing to have the conversation. So that's really important too. And this feeling of being witnessed is deeply healing. And this is one of the things that I think nurses are very good at, is that we are able to witness without necessarily having to rush in and do something. And this is communicated often kind of ineffably. Right? This subject talked about how there was just a look on the therapist's face like he understood. And I'm not sure how he understood, but I just sensed that he understood. We communicate that. We also communicate this just experience of being human. This subject talked about how, we get caught up in our lives and we sort of forget about what matters. and that the therapist could resonate with that having that experience of seeing yourself reflected in the therapist was really healing. So as I mentioned before, subjects can spring leaks during these sessions. We put waterproof pads down on our couch because people have been incontinent. It happens. You got to go to the bathroom at some point during the 7 hours. And if you've had drug, you often need help getting there. We also have touch patients therapeutically. So in this picture, that's Marcella Otalora and Bruce Poulter, who are the investigators at the Boulder site of the MAP study. Bruce is a nurse, and you see he's holding the subject's hand. That kind of touch would be agreed upon before the subject ever took the drug. And we would make it clear that they can withdraw their hand if they don't want it. They can say, don't touch me, but that we have these agreements about appropriate physical touch. And I think this is sort of natural for nurses. If anything, I think sometimes nurses might have to become more mindful about how they touch patients, because I'm thinking about a colleague of mine or a student of mine who was a ER nurse for many years. And then she went to become a psychiatric nurse practitioner. And in a practice session, a simulation rather, she kept touching the patient's arm in a very sweet and reassuring way, but probably like every 20 or 30 seconds. And in giving her feedback, I said, normally we don't do that in psychiatry. Touch is we're a lot more cautious around touch. And sometimes our profession gets so phobic around touch that people don't even shake their patient's hand, let alone hug them. So this is a little different. Obviously, the touch is always appropriate and agreed upon, but we got to be able to touch our patients. And what was this like for patients? Well, they said, the preparation made them feel safe. They felt really well prepared. And this was a subject talking about having to go to the bathroom. And she's like, normally that would be weird, but it was fine. It was Michelle. It was somebody I had trust in already. Then we also have to think about, where are we doing this? This is our own lab, our old lab, decor at UCSF. And you can see it looks kind of like a living room. I like to call it our funky Airbnb. And this was intended not to look like a hospital. So aside from the blood pressure machine, it's pretty non-clinical looking. We get fresh flowers each time we do this. And so we really want to create a safe, contained space where people can really dive into their own experience, and that environment is healing. Tim Leary famously talked about the set and setting. I mean, this has become such a trope in psychedelics, but it's important, that the physical setting has an influence over our experience, as does the mindset which we go into the session with. And Florence Nightingale knew about this. In 1860, she wrote about the environmental theory of nursing, saying that the first thing she did when she went into that hospital in Crimea was to open the windows, let light in, let fresh air in, and clean the place up, because it was filthy, apparently. She knew that the environment had a big influence on how we feel. And patients pick this up too. That when people come back for integration, they often are like, wow, this is where it happened. There's a warmth to the place. They want to get the soundtrack so that they can hear the music again, because it takes them back to that. So that environment really does matter. And then finally, getting to the end here, this idea of integration is so critical, because really what integration allows us to do is to make sense out of what can often be a really intense experience. In the same way that sometimes people will come back to a medical hospital and say, I was a patient here, I'm trying to make sense of what happened, I don't remember. Or at the end of a hospital stay, they'll say, what was I doing when I was in the ICU? People want to make sense out of their experience. And that's important, because these stories are what we go forward with into our lives. This idea of a psychedelic experience really being a critical moment in our time, where it becomes very clear that this is something the poet David White has talked about, that we live on this liminal space between that which is disappearing from our lives and that which is emerging. And Irv Yalom, the existential therapist, would often do this exercise with patients, where he would take a blank piece of paper and he'd draw a line on the left side draw a line across, and draw a line on the right side. Say the left side is your birth, the right side is your death. Where are you right now? You know, it's a big question, right? And it's a question that's worth exploring. And oftentimes these psychedelic experiences are big enough that they really invite that kind of reflection. And so finally, we've finished this remodeling project, right? Here's my house after. So now this is the place where I want to invite my friends to be. This is a place where you gather with family, because home is sacred, right? And we've now made it in a place, made it into a way where we want to live in it. This is what David White might call the house of belonging, right? And a lot of times, not much has changed on the outside, but the inner world has changed significantly. And you know, sometimes it only takes sort of clearing the windows to realize how beautiful it is outside. But the windows have been dirty for so long that you never realized what an amazing view that you had. And so this allows us to really re-inhabit this inner world that is ourselves. If you're interested in more of this, this is the organization that Ali mentioned that I helped co-found with several of my CIS nursing classmates. This is the Organization for Psychedelic and Entheogenic Nurses. It's opennurses.org. Those papers that I mentioned are on my website, which is andrewpennp.com. Actually, that should say .com, not .org. And so with that, I go ahead and stop sharing and would love to take questions. I see there's some in the chat, but however you want to do that, Ali, is fine with me.
Sure. Well, thank you so much for that lovely presentation. You eloquently described the patient journey and that experience in such a descriptive way. So thank you for that.
Thank you.
And we'll get started with the questions. So if people want to raise their hand and you can come on and ask your question, you will be on the recorded video. If you don't want to come on the recorded video, just drop it in the chat and I will ask the question for you. And someone's already asking if this is going to be accessible after, and it is. We're going to put it up on YouTube so you can check it out again. And while we're getting the questions started, I have one that comes up quite often, is people want to know what the difference is between the MDMA and psilocybin experience in this therapeutic context. And there's a lot of different indications being studied for both MDMA and psilocybin. And so if maybe you wanted to say a few words about how it looks differently or the same, would be interesting to hear about.
Yeah. You know, they're different animals. I mean, it's funny how we talk about psychedelic-assisted therapies, and then we lump these two things, which are about as similar as chalk and cheese. They're pharmacologically different. They are subjectively different. And so MDMA, what I've observed of that is that it permits a kind of self-compassion to emerge. And that it is, I'm going to use my own language against me. It's kind of shame-olytic, right? So a lot of people with trauma carry a lot of shame. I think a lot of humans carry a lot of shame. I think it's kind of a human condition. You don't think you have to have trauma to experience shame. And what MDMA really seems to do is it seems to allow that to just stand down for a little while, and for whatever experiences one had to be examined without feeling this sort of it almost like sniper-like attack of shame, you know, which comes in, oh, you can't talk about that, don't talk about that. If they find out, you know, because really at the heart of shame is, if you find out who I really am, you will exile me from the tribe. I will be put out in the snow to die, right? And so a lot of people with trauma carry that shame around, that if people really knew who they were, they would be unlovable. And I think what MDMA allows is for that to be kind of set down for a little bit, and for people to examine things in a different way. Psilocybin is a little more protean. I definitely feel like it has sort of a trickster quality. You know, you don't always know what you're going to get with it. I think it's definitely you know, if you think about what mushrooms do in ecology, they break down old material to make it into something that can be used by new life. And I think that metaphorically, that's what psilocybin does in the psyche. I think it breaks down stuff that is no longer serving us, but might be feeding our depression, for example. But man, does the psyche fight it. It's like, it's not going to go out without a fight. And I think that's sometimes why psilocybin can be more difficult than MDMA. I mean, MDMA has its own difficulties too, but psilocybin can definitely, you can get a good ass kicking with psilocybin, and it psychologically. And so it's tough. It can be tough. It can be like going through the tumble dryer. I remember when I was a kid, my mom would put my shoes in the dryer when I get them wet. And you just hear this boom, 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 boom. It's like, that's the sound of your psyche going through a psilocybin session. It's a little challenging sometimes. Nothing that can't be handled, but it's trickier. So, but I think what that does is it breaks down some of that old material so that it can be used for new life.
Great, thank you for explaining that. We had a question, it just came to me, and it says, how do you think the work might be different from nurse to nurse practitioner?
I'm not sure I fully understand the question. I mean, all nurse practitioners are nurses. That's sort of that's our foundation. I don't think this is something that's exclusive to nurse practitioners. I think nurses spend a lot of time with patients in non-ordinary states of consciousness. Ask anybody who's ever been in an ICU with a delirious patient. This is why I think that nursing is really well suited to this, because, people are like, wow, how can you be with somebody who's like all, out of it for 8 hours? I'm like, I've spent plenty of time in hospitals with patients with delirium for 8 hours who, thought that I was breaking into their house over and over again and I was in their kitchen. I'm like, I can roll with somebody who's in a non-ordinary state of consciousness without getting too weirded out by it. So, it's about that presence of quality of presence. And I don't think that's, I don't think that's exclusive to nursing. Let me be clear. I just think these are skills that are more, these are ethos that are more just sort of native to nursing, that I'm happy to teach other professions how to do it.
Yeah, this reminds me of Annie Mithoefer. She's a nurse and one of the therapists on the MDMA studies. And she talked to me about how, some of her and other nurses she worked with, that it felt more natural in a lot of ways to be able to do the non-directive approach and just follow and support the patient wherever they were. Whereas her husband's a psychiatrist, and psychotherapists really get trained up with trying to guide or ask questions or go in certain directions. And she felt that in a lot of ways, it was easier for the nurses just to pick up on this natural way of following what's coming up. So this profession is well suited, I think, as well for the treatments.
Yeah, I have a paper that I collaborated with some nurse midwife colleagues recently. It's going to be in a journal of nurse midwifery, hopefully. And we were talking about how close this being psychedelic therapy, to the native sensibilities of a nurse midwife. Because what do we do as nurse midwives? We allow a natural process to unfold, and sometimes it gets a little stuck, or sometimes the person gets really scared, because they don't think they can do it. And it's not about swooping in and saying, okay, we'll fix this. It's about coming in and saying, you got this, and I'm here with you, and I'm not going away, and you're going to be okay, and we're going to get through this together. And like, you've got this. I'm not doing this for you. You don't need me to do this for you, because you can do this yourself. And I'm here to support you in that. So I think that idea, and let's remember too, to centralize this where it should be, is that, this medicalization of psychedelic medicines is a fairly new phenomenon, right? That who were the medicine carriers through antiquity? Largely women. And who were the midwives? They were women. So people that know how to do this, they get overwritten in the way the story gets told, but that's we're fools to overlook that wisdom, that pooled wisdom, and not to learn from it.
Yeah, that's a great segue into the next question, was about what are the long-term effects of psychedelics on the brain and body. And I can just throw in here too something about the courses that we offer on psychedelic support. We go into great depth with MDMA in particular about what's been shown in the non-medical settings. Like, there is a lot of evidence about these compounds. You know, they've been around for many years, and so we do a good review of what we know from recreational settings, as well as what's been found in clinical settings. And what's important to think about is the dose, the frequency, the purity of the drug, which is all very well controlled for in these studies. And as far as the longitudinal studies that will come to pass in time, we do have evidence from MAP studies about treatment effects for MDMA, which is shown to be pretty long-standing for a number of participants. And that's very encouraging that, you know, limited number of doses can really reach the outcomes that are necessary for a therapeutic response. But I don't know if you have anything else you want to say about that, or we want to go to the next question.
Well, yeah, and I see that Daria has her hand raised.
Yeah, we'll let
Do you wanna
Daria
get
go
her?
next since she's
Yeah,
brave
but
enough to come on up.
I'll take a stab at the question. I mean, one thing that we have seen is in the long-term follow-up studies, from the therapeutic aspect, is that these benefits appear to persist for many people, often for many years, which really speaks to the kind of deep change that occurs, because clearly it's not pharmacological effects. You know, there's no MDMA that lasts for 4 years. Thank God. That would be a hard place to live. But, you know, so the point is that the benefit seems to last. As far as the risks go, you know, it's always a very tricky question to answer, because, you know, when that's looked at in recreational drug use, there's so many unknown variables. Some of the things that Ali pointed out, you know, you don't know what people actually took. You don't know what dose they took. They often take it in combination with many things. I mean, this is total pharmacology trivia, but there is a small subgroup of people in Salt Lake City who are members of the LDS Church who don't drink, don't smoke, but they take MDMA in party settings. And I can't remember the scientist who studied them, but there's such a unicorn, because usually anybody who you're studying, if you want to study the effects of, say, MDMA, recreational use, they drink alcohol, they smoke cigarettes, they take other drugs. And how do you separate out the effects of MDMA in the long term from those other drugs, which do have long-term effects? You know, but I think in these kind of controlled settings that are as structured as they are, I think the risks are likely to be relatively minimal. And, you know, this sort of long spoken of but infrequently seen hallucinogen perceptual disorder, I can never remember the exact HPPD, you know, people essentially having flashbacks, and that has not really come to bear. I mean, there are people that report this, but often when you look closely at it, it appears to seem more like an anxiety variant. But anyways, that's probably something for another topic. Daria, did you have a question that you wanted to ask?
Yeah. I wanted to, it's not really a question, maybe, like I don't really expect you to have a clear answer, but I want to hear your thought on where can I start? What shall we do in countries where psychedelics are illegal and clinical trials on psychedelics are illegal, but there is community of people who are taking psychedelics illegally. Mm-hmm. And there are communities of trip sitters and all kind of, I'd say, helpers, mm-hmm. Like from harm reduce programs, from some spiritual sides, all kinds of people trying to help people to take psychedelics in more responsible and more helpful way. And from the other side, there is psychotherapy community and psychotherapy training, and which is very clear about like not crossing low borders, because they can't actually pursue you in court but they can, kick you out of the community. So
Mhm.
I'm sorry, I have so many thoughts here because I live in Ukraine. In Ukraine, psychedelics are illegal. Clinical trials on psychedelics are illegal too. Even cannabis is illegal. Even medical cannabis is illegal. And I'm patient myself. I have borderline disorder, and right now I feel very aggressive with our local psychotherapist community because through all the 6 years of my psychotherapy, I feel like there is a bad part in me they want to get rid of. And I'm like, okay, leave my bad part alone. I'm okay with it. I love my bad part. I hate you guys. and I started training to be a psychotherapist myself this year because I'm all tired of local psychotherapists and I want to be a different kind of psychotherapist to help person who are
Yeah.
like me. And nursing books, especially Jennifer Worf books, really resonated with me. And I'm always like, okay, why psychotherapists don't read this? There's a piece of advice. It's from the middle of 20th century and it's so useful. And so right now I'm really interested in psychedelics and I'm really interested in becoming a different kind of psychotherapist, but I don't know where to look for and where to start. My best idea for now is to wait for internal family systems training because it's the only psychotherapy I know which states explicitly that there is no bad parts. But I don't know what to do. And as like I'm a trainee, I know something about psychotherapy. I know something about psychology. I know a lot about biology because I was a geek in school and I had a really good teacher. And I have friends who use psychedelics and they have their experience about psychedelics helping them with their psychological problems.
Yeah.
And I don't see any point in future where these lines cross.
I'm not sure what to say about the legal aspect of these things and how to do that in a country where there isn't any means of supporting that. But one of the things that you point to there that I think is helpful is having more narratives. One of the things I love about nursing is that we are a qualitative profession. I mean, we do some quantitative work, but we're a profession of storytellers. And I think about when we give report in the hospital to the next shift, we're essentially giving a story with data points, but we're saying, we're telling a narrative. And there's a lot of power in those narratives. And qualitative work is often kind of disparaged as not being as rigorous as quantitative work, which I take issue with. And I think we have the quantitative data. I mean, and we're generating more of it about how that say, look, this person had a Hamilton depression score of this before they went in, and now that's this, and therefore it got better. But I want to know what happens between those 2 points. I want to know what happens subjectively for that person. Like, it would be really interesting, Daria, you were talking about your own mental health struggles, to have narratives where people talk about, like, yeah, there's this part of me that is kind of makes trouble, but I'm not about, it's not a, Jung talked about this, that like we don't cut parts of ourselves off, we integrate them into the whole, right? And so how do you change your relationship with that part of you that maybe at a younger point in your life caused more trouble for you? What was that experience of befriending that part of you? Or I don't know if you befriended it or if you just make whatever you did, but I think having those narratives, especially from multiple sources around the world, because, Lord knows there's enough white people in America who've been treated with these in clinical trials, so let's see what this experience is like when it's done with people who live outside the United States or people of color, people from other parts of the world. Let's understand that better. So I think that qualitative piece, I don't know if I really answered your question there, but I'm trying.
Yeah, well, thanks, Andrew. We're going to wrap it up because
Okay.
I know you have a lot of busy work to do today, and we appreciate your time here. So sorry we didn't get to all the questions, but if anybody wants to email me, I'll try to answer your questions or point you in the right direction at info@psychedelics.support. So thanks for joining us, and everybody have a wonderful weekend and take care and be well.
Great. Thanks, Allie. Appreciate the invitation.